We're going to talk about screening. As you all know, that offering screening to the patient has almost become like standard of care. And we do screening for disorders with a common prevalence. And one of the conditions we are taking up is for Down syndrome. And then preeclampsia screening has also come into practice. Now, apart from Down syndrome, a byproduct is screening for trisomy 13 and 18. But we are supposed to screen for disorders with a significant impact on perinatal morbidity and mortality. And however much I look at, I'm not able to understand that Down syndrome has got a very high perinatal mortality and morbidity. Because today the life expectancy of Down syndrome is more than 70 years. And with early intervention, many of them are actually doing reasonably well. But still, our focus is on screening for trisomy 21. And the question is universal availability. Yes, today it is available for those who can afford to have it. So let me ask my panel, what all can we screen for in pregnancy? Boban, you want to take it up? What all can we screen for in pregnancy?
Good evening, sir.
Yeah.
Actually, we can screen for aneuploidy.
Yeah.
Also, we can screen for preeclampsia screening can be done. And
what about preterm birth? Sinish, you want to take about cervical length? We are able to do it.
Yeah, cervical.
Anyhow, we are doing a transvaginal scan.
Yeah.
Why not do a cervical length?
Cervical.
And can we screen for it in the first trimester?
Hi audience. So regarding preterm birth, I think we have largely failed, though we have an effective tool in the form of cervical length monitoring. And I can remember of 2 studies which has been done in this field. One study showed some benefit, but the study that followed that did not show any benefit of even endovaginal cervical length monitoring in first trimester.
So, but you'll agree it is not standard of care at this point?
At this point, it is not a standard of care
Okay.
for first trimester.
So now for screening for aneuploidy, can I push the mic to, no, I'm not able to see from here. So what are the tools that are available for screening at this point of time, for screening? Yeah.
The most commonly used screening markers are
Loud, I'm not able to hear.
The most popular markers are nasal bone and nuchal translucency, but there are additional markers like tricuspid regurgitation, ductus venosus A-wave changes, and sometimes ARSA as well, aberrant right subclavian artery.
So you're talking about ultrasound markers, right?
Yes.
Do we look for all the markers in all the babies, or you have a preference to 1 or 2 markers?
For general screening purpose, at the moment, nasal bone and nuchal translucency are mainly looked at.
Okay. And so during the screening process while doing the ultrasound, apart from the nuchal translucency, what other measurement becomes very, very critical? If you do that measurement wrong, then the whole screening process goes wrong.
The CRL.
The crown rump length. So here's the crown rump length, which need to be absolutely perfect, because every screening report which you see, you not only look at the NT image, but also look at the CRL image. Because if the CRL is wrong, then that NT is not valid anymore. Now, what about the other tools? Any other tools available?
We have the maternal age, which was the earliest method of screening.
Yes.
Then we also have serum parameters that we look at, PAPE, free beta HCG.
Okay.
And if you're looking at preeclampsia screening, yes, you've listed these out, PLGF and
So more
SK.
recently, apart from PAPE and free beta HCG, they've added PLGF and alpha fetoprotein also as an extended screening possibility. And may I ask, why are we having so many screening parameters? That tiny little baby, we are doing so much, every part of the baby we are looking at it, and adding so many biochemical markers. Does it mean none of them are good?
We haven't found the perfect one which would detect everything. All the cases, we haven't found that one perfect screening method by which we can detect all the cases. The more you add, you're increasing your detection rate and bringing down
So you have to accept with a few. So what are your preferences then? If you say all the markers I can't do for everybody, which are the markers which you will routinely do for at least this minimum I will do for everybody?
NT, PAPE and beta HCG, free beta HCG.
You are happy with that? So among 12, you are choosing 3. Good enough for you?
Yes.
The sensitivity and the yield from that, you are happy with that?
Yes.
Okay. Let me go on. So now there are some factors which affect the screening process, and there are patients where you will want them that the screening maybe sensitivity is affected.
Yes, actually, good afternoon, Trishur. I don't know, out of the box. I don't know when I see Suresh sir, again butterflies come through the stomach. Anyway, so sir has actually made it quite clear. So filling, I have to change to a different way. Filling the TRF form is very important when you apply for that. I think that is the applied aspect of this one. Because if you don't write diabetes, and if you don't write twins, if you don't write IVF, and these are the situations when the screening can go wrong. Yes. So actually I'm answering indirectly like, what sir have asked.
So you're emphasizing the fact that while requesting for a screening, you must fill in all these factors correctly.
Yes.
And what about if there's a previous baby with Down syndrome?
Yes.
Is that important, and how does it become important?
If the previous baby is affected with Down syndrome, some algorithms by default gave it as high risk actually.
Yes.
So that is the issue. But this is a contentious issue and there is no uniform way. Yes. Some guidelines suggest that if the previous baby is having Down syndrome, this is pre-NIPT era, we used to go routinely for invasive testing. But the post-NIPT era, it is quite acceptable to go for NIPT also, depending on the ultrasound finding actually of this pregnancy.
So you have opened up a sort of Pandora's box saying that when there's a previous history of Down syndrome, you would go for NIPT. Now, Sinish, can I ask you a question? That if you're going for NIPT, is this history really important? The history of previous Down syndrome, is it going to change your NIPT result?
No, NIPT, that is non-invasive prenatal test, is not based on maternal age or any demographic factors. It is based on quantitative assessment of cell-free DNA in maternal circulation. So the history doesn't matter in that.
The history doesn't matter there. Okay. So now comes the question, are there women where you will not offer screening at all? You'll say, no. For you, no screening. You have to go. If you want to know about Down syndrome, you go and have an amniocentesis.
Screening is done for in an otherwise normal or a expected normal pregnancy. So if you've seen ultrasound markers which are clearly crying out that there's an abnormality, it's better not to screen but to go for a diagnostic test.
You're saying ultrasound markers or structural defects?
Anomalies also. Like you have an absent nasal bone, D-wave reversal, TR, these are markers. But
absent nasal bone forms part of your screening protocol also, isn't it?
No, basically it's a NT which is being measured, and the NT, if it falls more than 95th centile, then probably we can offer for a diagnosis.
If there is a marker which is directly related to the abnormality, say for example atrioventricular septal defect in the first trimester is a marker of Down syndrome, if you see that particular anomaly, you don't have to go for screening, you can straight away book for diagnostic testing.
Okay. So you opened up something saying NT above the 95th centile. Okay. So is it NT above the 95th centile or do you want to give a particular number saying beyond this NT, I will not do screening at all?
Beyond 3.5 mm.
3.5 mm. Okay, let's go and then look at cases. Now comes the question of a person comes to you and says, Doctor, give me the best test for screening for Down syndrome. Best test means beyond this, there's only one other test where I have to go and do an amniocentesis.
As of now, cell-free fetal DNA is the most sensitive and specific one.
Cell-free DNA. And what is when I say best test, how better is it by doing routine screening?
It has got a very high positive predictive value compared to the combined first trimester screening.
Okay. Now from
sensitivity of NIPT is as close, for detection of Down syndrome, is almost 99.5%.
So far we were talking about sensitivity and suddenly she gave us a number called positive predictive value.
If you use cell-free fetal DNA, the number of invasive procedures which you have to do will come down drastically.
Come down drastically, but still you have to do it, isn't it? You still have to do it in
Yes.
case screen positive.
Yes.
Okay, right. So the sensitivity is over 99.7% as said, and the positive predictive value is about 50 or so. So which means for every 2 amniocentesis you do, you'll find out 1 Down syndrome when you do NIPT. Now that you've said you've got a fantastic test here, why not we save time and forget about all the ultrasound markers? Anyhow, one person saying absent nasal bone, another person saying present nasal bone, NTs are being differently. Why not just give NIPT for everybody? Good choice?
No.
Sin?
Ultrasound, we should do a good NT scan and look for the markers. Even though we are doing, and patient is opting for NIPT.
I am giving you a test which is 99.7%. Okay? And for that one condition called Down syndrome. Okay? Simply mother's blood test, 99.7%. Instead of wasting your time looking at measuring the NT and then suddenly the baby goes behind.
There are so many conditions that can be diagnosed by ultrasound alone, like anencephaly and...
So, which means you agree that for Down syndrome, this is the best.
Yes.
But you can't leave out others.
Yes.
Correct?
Yes.
Okay. Then comes the question of, are there any conditions where you cannot offer this best test? There is a best test available, but are there conditions where you won't offer this best test at all? NIPT, sorry, no NIPT for you. Can you say that?
If you do a scan and if you see any structural abnormalities, or if the NT is more than 3.5, then definitely no screening. There is no role of screening in that case, because NIPT is a screening test.
Or if there is a twin.
Or if it's a vanishing twin, in a twin pregnancy, if there is a vanishing twin, also NIPT can give spurious results.
Yes.
If there is a twin with one structural abnormality, again we cannot do that.
Okay. So let's come to the question of vanishing twin. Okay. So here's an early pregnancy where there were 2 babies and one simply vanished and the other one is there. So why not do NIPT there? What's the problem?
The vanished twins, beta HCG may interfere with the result. And free DNA may interfere with the result.
The cell-free DNA will have from the vanishing twin. So can I say here is a vanishing twin where the sac is empty, there is a sac with a fetus inside. Does it matter?
No.
Does it matter? When you see 2 sacs, you say no NIPT. Okay, thank you very much. So now comes the question of NIPT has got high risk. It has come as high risk.
So at the end of the day, NIPT is a screening test.
But 99.7%.
It's not 100% yet.
Not 100%.
But when I do a CVS, I have a culture failure, and I do an amnio, I've got a culture failure which is the same 0.4%, isn't it? So
You can have false positive and false negative with an IPT.
So unless you see the chromosomes with your eye, you're not going to say yes or no, isn't it? Okay, right. Now, let's go look at, can combined screening be done in twins?
Yes, we can do combined first trimester screening for up to twins actually. It can be either a dichorionic twin or a monochorionic twin.
Okay. And are we as accurate?
No, we are not as accurate as a singleton pregnancy, but it is a reasonable method of screening.
Okay.
But with the
Now,
advent of NIPT
what about this picture I've shown you? This patient comes and says, Doctor, I want to retain all my 4 babies and I want to rule out Down syndrome in all 4. Please tell me what to do.
We have only NT and CRL based, maternal age based criteria to calculate the risk actually.
Yeah.
And of course, we can add on to our sensitivity by seeing the other markers like ductus venosus or tricuspid regurgitation.
So that brings us to a very, very good question, because NT, age plus NT alone is only about 70%, right? Now, I'm going to push the boundary and do all the ultrasound markers, like ductus venosus, tricuspid regurgitation, everything under the sun. Will it be equivalent to doing combined test with the biochemistry?
No.
The percentage, will we get close to around 85-90%.
So I want to add here that if all the markers are done accurately as per the FMF UK guidelines,
Yes,
at least on paper, the sensitivity reaches up to 95% or greater.
95%.
95%.
Okay, so that's right. Now, let's push P screening aside and let's go on to scenarios now. So this is a patient with the first trimester screening done at 12 weeks, and she's referred at 13 weeks, 6 days. Okay? And this is the report that has come. Free beta HCG is 2.86 mom, PAPA is 0.98 mom, combined screening result is 1 in 335 screen negative. Okay? But in the same report, there's also another number called double test 1 in 225 screen positive. So this woman is carrying a report which has screen positive and screen negative. So will we average these two and give one risk or what?
No, once you do combined screening, you should only take that risk as the final risk. You should not be interpreting it individually.
So should this double test be reported at all in the first place?
Double test is something like the old triple test, which is obsolete actually.
It's obsolete. Okay. Now the question is, are you concerned about these values, the free beta HCG and PAPA?
The beta HCG value looks abnormal.
Okay. So you have to discuss the result with the couple, and you just told me that forget about the double test, I'll go with the combined screening, 1 in 335. Can we call her a screen negative and reassure her?
No, she actually comes under intermediate risk.
Intermediate
risk between 1 in 100 to 1 in 1000 is considered as intermediate risk. Considering her age of 34 and that by beta HCG high, I would recommend her to go for an IPT.
You'll go for an IPT. Okay. But would you like any other information?
I would like to see the NT image.
You want to see the NT image? Not trusting your colleague or what?
Also, if she's taken any HCG injections, because
Also,
that can influence.
Also, if she has taken it. So, she has taken a HCG injection on 8/1 and sample was drawn on 11/1. So, now comes the big question. Okay, you wanted to review the NT images. So, here's the NT image and CRL image for you.
These images are not satisfactory.
Okay, so you're not happy with the images?
Not happy with the images.
So you're not happy with the fact that she's taken HCG, you're not happy with the fact the NT is taken, so now I have a lot of options before me. Go for invasive testing, because anyhow you got intermediate risk. Second is rescan at 16 weeks and do a genetic sonogram. Ignore the results and redo the FTS in a different lab, or do NIPT, and since it's screen negative, option of expectant management. So what will you do?
Invasive testing, I feel we don't have, the screening was done very poorly. We don't have enough reason to ask for an invasive testing. Rescan at 16 weeks and to do a genetic sonogram, I feel it's the last resort. I won't use that as my first option. Ignore the result and redo FTS in a different lab. Again, 13 weeks, 6 days is very close to the cutoff. Difficult to get an NT.
Today is the last day. 13 weeks, 6 days is the last day. Tomorrow, no.
Yeah, if I get a very unlikely to get a good CRL and NT at 13 weeks, 6 days.
Okay.
But yes, I can try and give it as an option, but probably NIPT is what I would go to.
You would look at. So, you would look for NIPT because we need to move forward at one level. Because it's a badly done screening, you will still give the benefit of the doubt to the baby, isn't it? Okay, so important thing here is whenever screening is done and you're having results, you need to audit the images and the report. If the NT is suboptimal, you have to ensure that, because this is the one which is driving the screening process, and report should have only one risk to do that. So let's move on quickly to the next scenario. She's 38 years old, okay, 2 babies alive, 1 miscarriage, 2 miscarriages, and 5th is a present pregnancy. And present pregnancy is a surrogate pregnancy. Age of the surrogate is 28 years, and the FTS risk is 1 in 3,900. NT taken well? Are you happy with the NT? Taken well. So we will accept this. And then at 17 weeks, they order a quadruple test. Okay, these are all real cases, not made up by me. And the quadruple results gives T21 risk of 1 in 33. From 1 in 3,900 risk, she became 1 in 33. Is that possible? Has the lab done something wrong?
Probably they have taken the maternal risk, the surrogate's risk. Maybe in case of surrogate pregnancy, we have to calculate the age of the
So
ovum or the embryo donor.
No, whose age should go?
The biological mother.
Donor's age should be used.
The biological mother's age should be
Biological,
taken. Whoever has given the egg should
So
be
which one was wrong? Was the first trimester screening wrong, or was the quadruple test screening wrong?
Quadruple
Because
is
if
wrong,
you look
I
at the first trimester, age risk is 1 in 850.
Mostly she may have taken the surrogate mother's age.
for the first trimester.
Yeah,
screening.
this was the surrogate mother's age, and this is the biological mother's age.
Biological mother.
So whose risk should come? You prefer the biological mother's age should be put, so you have to accept the quadruple test.
No, actually.
This is the problem in doing 2 tests on one
No,
patient.
in the screening, actually, we have to use the age of the whoever has donated the ovum or the embryo.
Correct. So in a
That's
surrogate
it.
mother, it is her ovum which has come into the surrogate mother.
In this case, because she's 37 years old, I think it's
So that is
Actually, her
included in
age was
IPT.
used in quadruple testing.
Okay. So I'll give you these choices. Accept FTS, ignore the quad test. Accept quad and ignore the FTS. Leave the choice to the woman, saying here are 2 risks for you. You decide whatever you ask, I will do for you. Repeat the screening or again go for NIPS.
I think this is reasonable for an IPT because she's 37 years old.
But you'll go for?
An IPT.
I
You'll
think,
go
sir,
for
whenever
an-
there is confusion like this,
Pardon?
whenever there is confusion like this, when a lot of tests have been done and all, I think NIPT is a good option to go at the end.
So, see, all roads are leading to NIPT now. Anything finally, it's leading there. Okay. So the question is, can NIPS be done in a surrogate?
Of course, yes.
Yeah, yes.
Because this surrogate's mother's DNA and this baby's DNA will be completely different.
So NIPS is basically placental DNA, the placental DNA, so which is of fetal origin.
We
So-
just need to inform the lab that we are using surrogacy so that they will not be surprised not
But
to
should
see
you
the maternal
inform the lab
control.
about the surrogacy?
Yes, we do.
Okay. So it's very important to inform the lab about surrogacy. Now, from 10 weeks onwards, for all single identical twin pregnancies, including IVF, egg donor, or surrogate pregnancies, NIPS can be offered. For non-identical and vanishing twin, the test sensitivity is reduced, and that's what you do. So quickly go to the next. Somebody has to keep track of time because I've got 2 things. Tell me. How many minutes for this panel? Okay, then we'll quickly finish it. So here is a case with the NT 3.2, beta HCG 1.6, double marker test screen negative for T21, 1756. Okay, and then the patient now changes her obstetrician. Okay, that's what commonly happens in our practice. She was referred for 19-week scan, and the second obstetrician, who was very, very recently, she had attended a conference on screening, and she said, I'm looking at the result here, the double marker test seen negative, but why have they not included the NT in the result? The NT measurement is there, it is not included in the result. This is what happened. So now what do we do? She's 19 weeks already, and in the first trimester screening, they have done the double marker, given a low risk, but NT was 3.2 and it was not added in the result. So we need your help.
I'll do an ultrasound first. She's at 19 weeks. It's the ripe time for an anomaly scan. I'll take a look at the structure and assess as part of the thing.
Okay, here's a structural for you. Everything normal.
All right. So, because the NT was 3.2 and the maternal age is 35, there are 2 high-risk factors in her.
Okay.
And she's already 19 weeks, 2 days.
Yeah.
So, the 2 options that are left for us are either NIPT or amniocentesis.
So I'll ask a question. Can we work backwards? Can I say, okay, here is a lab whom I know, okay, and I've tell them, oh, you forgot to put the NT image, so here is the NT result. Go and recalculate the result and let me know.
I think FMO,
yes.
we can recalculate the risk actually. If the blood was taken accurately and we have the date for that,
Yes.
and the NT date is also there, then why can't we recalculate? We can recalculate. Sir.
You can recalculate.
We can.
And everybody agrees? Some
Yes.
disagreement?
Yeah, all this is possible, but since NT is 3.2 millimeters, and it depends what kind of fetal medicine practice we are doing. So I like to be on aggressive side. 3 to 3.5 is not a safe zone. And it's not just the structural anomalies, single gene disorders are all possible in this group.
So
that's
now,
the data pouring in.
now Sinish has taken us to a slightly different area. First, I asked a specific question, is there a cutoff of NT where you will do only invasive procedure? And he said 3.5, okay? And then now he says between 3 to 3.5, it's a sort of a high risk zone, correct? So should we have it at 3 instead of 3.5?
That depend. I think that is best left for the individual choice. But in our practice, 3 mm and more, we are directly offering invasive test.
Okay.
Beyond, even we are thinking beyond of carotid.
Right. So we recalculated the risk. As Prashant said, we went back and said, okay, please recalculate. Final risk is, of course, greater than 1 in 50. It was screen positive, as expected. With a 3.2 NT, you can't have a low risk because NT is treatment remark. Okay, next case. Now NT we are pushing the NT a little bit more, which is 3.3. Okay, and she's 12 plus 6 weeks by dates. No tricuspid regurgitation, ductus was normal, nasal bone was present, everything was present. She's 22 years only. Okay, now what would you do? You said you will do invasive. So direct testing as increased. Patient opted for direct testing because you told her. CVS was done and the CVS said no sufficient tissue on 2 passes. So the direct testing which she went to, they said, sorry, no, sample not sufficient. Now we are stuck. You want direct testing in this lady and direct testing has failed.
You can wait and do amniocentesis.
16 weeks call her back and we can probably do amniocentesis.
Keep it close and clear.
We can call her back at 16 weeks and we can
call her back at 16 weeks
and do amniocentesis.
And do an amniocentesis. So she went back her OB. Her OB said, no, don't go for amnio. Do NIPT. We have one fantastic test called NIPT. So does this road to lead to NIPT also? Possible? Or you're not comfortable? Because you are the expert. He has come for an expert opinion
now. NIPT, the practice regarding NIPT in the present scenario is an end product of extreme marketing that is happening. Yes. For NIPT, the way companies are projecting NIPT, and since the obstetricians, they find it, I mean, the information they are being told. Even I saw some radiology reports, NT 3.1 millimeter suggests NIPT. Previously, there was a scenario where they used to write suggest combined test or suggest amnio, but even now the radiology reports are suggesting do NIPT. This is something we should be worried about.
So I want my panelists to tell me, in routine practice, is it okay to go should we have combined screening and then take the intermediate risk for NIPT or go for NIPT directly?
Combined screening followed by NIPT.
Message we want to send.
Definitely combined screen followed by NIPT.
So while doing combined screening, you're also scanning the baby very meticulously. You have the opportunity to see the baby very well. And there are several centers who do very early NIPT at 10 weeks. And then this patient comes at 12 weeks, we find there is anencephaly. Then the entire NIPT becomes a waste. So very important is to try to keep your screening time where we can maximize the benefit and also minimize the other risk which is there. So my question is this. After doing a CVS where you have disrupted the trophoblastic tissue, can I do NIPT? Is it okay to do? And or having started an invasive process should be completed? And yes.
It has got medico-legal implication now because we've already started doing the diagnostic procedure.
Yes.
And because we fail, we are going back to the screening, which I don't think it's ideal.
So you don't want to go back to screening? Go only in the forward path, don't go backwards. Is that what she's saying? So now the patient says, see, you tried once, you failed. What is the guarantee you will succeed again? I don't want to go through any invasive testing, leave me alone. And then the baby is born Down syndrome.
So we would have counseled the patient before we did the procedure about all these possibilities.
Okay.
So if she opts out of it, it is her will, but then we'll take it in writing. That
No, if she opts out of it, are you going to safeguard yourself in some way?
I will put it in writing. I'll ask her to write it down for me that it was her choice not to go for an
Right.
amniocentesis.
So the couple opted out of screening as further testing. 19 to 20 week target scan, one aberrant right subclavian artery has come now. Now what to do? They are now saying, doctor, every time I come, you are telling me something new. So please terminate the pregnancy now. Are we justified?
I would again go counsel her and about amniocentesis.
You will still counsel her about
Yes.
amniocentesis.
Yes.
Okay?
No termination.
You must have the power of convincing.
Yes.
That because she has declined it already twice. Yes. What?
I just want to ask amongst us, like in URSA alone, I mean, have you ever got aneuploidy positive in your cases?
No.
URSA alone, is it?
Correct.
Sir, I want to add one point actually.
I want you to fight with each other on this. That's the basic reason why I put.
So why not NIPT, like, when we failed with this thing, for the primarily, like, I want to take the umbrella of a guideline here. UK FASP guideline clearly says that between 1 in 10 to 1 in 1000, you can do NIPT. So why can't we do it? What is against NIPT?
Nobody has
the
told
patient?
that we can't do. They have used, I mean, you only said it can be done, right? But here already the NT is more than 3.3 millimeters. And now we have another marker.
Our cutoff is 3.5 millimeter.
I think I will go with the Anita approach,
Plus
where we
there's an
document.
ARSA. Now
We
this
will document.
ARSA, if you take ARSA isolated ARSA is not
Isolated ARSA, it's not
significant.
a major issue. Of
So-
course,
So do
it
you want
slightly
to,
increases the risk of like digorges or.
but in the setting of an increased NT with an ARSA
Yes,
Yes.
that
in
may
the
be
second
significant.
trimester, are you going to give importance to that?
Yes.
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 Are there any clear-cut answers here? Do any of you see clear-cut answers in this case? So is there anything right and wrong? Actually, there's nothing right and wrong here. Because if you want to give a final answer, yes or no, and invasive testing will give you the final answer. Because she was already positive for invasive testing, and the indication for invasive testing was there. And so it would have been there. So that is the final answer. But because she requested termination of pregnancy on these grounds, you'll all agree that termination is not an option
No.
to be given. Okay. Right. Now let me quickly go through, because we run out of time. And let's look at this. Last two cases. Natural conception, she's a monochorionic twin, 74 and 75, CRL. So here are 4 options for you.
Age plus combined test.
Pardon?
Age and combined test.
Age plus NT or?
NIPT also.
For
Again,
monochorionic, twins, you can just go like singleton pregnancy, like with combined first trimester screening and maternal age. If something goes wrong, you always go for an IPT.
Okay. Others, please, quick.
I will go for, combined test is the most effective test. So this is monochorionic twins, first ultrasound examination, of course, after that combined test.
Very good. So you would go for age plus combined test as a first screening option.
Okay.
Boban?
NIPT is also an option.
You also had NIPT option. So we'll give you NIPT also, either one. But one thing, Sinish, I'll tell you, I am not here to promote NIPT. Okay. I am just telling you, these are the real facts which happened. So here is a MCDA twin, slightly different scenario. One baby has got unossified nasal bone. The other baby has got unossified nasal bone and tricuspid regurgitation. And this is an MCDA twin. Should we still go for NIPT?
No, we have to offer a direct testing, CVS.
But NT is normal.
We have 2 markers
still two
here, and it's an
markers
MCDA twin. So straight away, the CVS will be ideal.
2 markers. But the primary marker NT is absolutely normal. These are all fringe markers which come on the side. Sinish?
Unossified nasal bone in itself is can be considered as a major marker in the first trimester, maybe not same as NT. And then there is another marker here, TR, and then it's a monochorionic twin gestation. So definitely we have to go for an invasive test as first
Okay.
option.
So you rule out NIPT in this case. Everybody agree?
Yes.
Okay. So direct testing, and direct testing gave the answer of Down syndrome in this particular case. Okay. So the direct testing, we did prenatal BOBs, and that gave us Down syndrome. We told, wait, let the culture report come, we'll see. And there's a culture failure. Culture failure. Should we repeat the culture, or can we act on the BOBs result?
We can act on the BOBS results. Actually,
So rapid karyotyping,
yes,
like QFPCR, FISH,
yes,
BOBs,
you can act on them.
reliable enough for you?
Not, but there are, yes, I would act on them. We have seen an unossified nasal bone and a TR with the positive BOBS.
Any disagreement with my panelists?
I think I will disagree. Karyotype is a gold standard test. So unless the gold standard test says it, I think I will wait for the gold standard test here.
So there's one.
Culture failure can happen, especially if there is.
I think better to vote here. Better to vote. I have 6 there. So please tell me, I will accept rapid karyotyping for trisomy 21. Yes?
I accept.
1,
This
2,
is my practice. I
3,
accept
4,
the rapid.
5. So 5 out of 1. So rapid karyotyping is reliable for trisomy 21. QFPCR, prenatal BOBs and FISH are quite reliable for trisomy. If you don't have anything else, because I can't go and do a repeat culture again. If I do a repeat amnio, I'm not sure that it's going to work. But she has an answer already of Down syndrome. So I would prefer to go on that. If I had the luxury of time and I'm looking for something else, like is it a translocation or is it a structural rearrangement I'm looking for, then I would look for that. Okay, so patient opted for discontinue. Right, I think we are done now. Okay, that's all.